This module describes the assessment and management of children presenting with school refusal and problems with elimination to primary care institutions. First, we will discuss about the prevalence of school refusal and the possible causes of this problem. We will also discuss on how to assess a child presenting with school refusal, primary care, and the appropriate management at the level of primary care. Roughly, 5% of referrals to child and adolescent mental health services present with refusal. School refusal is not a diagnosis but a presenting complaint that can reflect a variety of problems in the child or adolescent or in the family or school system as a whole. School refusal peaks at 3 stages: on starting school, after school transfer, and in the early teens. School refusal is equally common in boys and girls. No one socioeconomic group is particularly vulnerable. School refusal may present in several ways. The child or adolescent may refuse to go to school or may go to school but return home before or shortly after arriving at school. Or they may complain of somatic symptoms such as abdominal pain, nausea, or headache on school mornings. Absence of these somatic symptoms during weekends or school days is a helpful clue that the symptoms are of psychological origin. Child may cry, have temper tantrums, or behave aggressively when the parents attempt to send him or her to school. School refusal can occur due to environmental stresses or underlying psychiatric disorders. School refusal may occur as a result of a stressor at either school or at home. Stressors at home which may lead to school refusal may include recent death of a family member or close relative, recent major illness of a close relative, changing place of residence, or ongoing domestic violence at home. Even happy events such as the birth of a new sibling may trigger school refusal. Stresses at school which may lead to school refusal may include punishment by teachers, bullying, academic difficulties, and lack of friends. Stresses on the way to school, such as bullying by children in the school van or bus, may also result in school refusal. Psychiatric disorders can also lead to school refusal. In young children, separation anxiety is a common cause of school refusal. These children may worry that something bad might happen to them or to their parents while they are separated from their parents. Often, these children will be afraid of being without their primary caregiver, even when at home, and will have trouble sleeping without their parents. They may complain of somatic symptoms such as abdominal pain or headache when they are separated from their parents. Depression is another common cause of school refusal. In these children, school refusal will also be accompanied by other features of depression, such as low mood, lack of interest in previously enjoyed activities, irritability, deterioration of school performance, sleep disturbances, and changes in appetite. Social phobia may lead to school refusal, especially in adolescents. Children and adolescents with social phobia will worry about being judged by others or being embarrassed in front of others. They may worry about speaking or performing in front of others and will avoid such activities. History should be taken from the parents and the child separately. The duration of school refusal and whether there have been previous similar episodes should be inquired. The aim of the assessment is to find out the cause of school refusal. Any significant events at home or school that may have precipitated school refusal should be found out. Any chronic environmental stressors such as marital disharmony or domestic violence should be queried. Symptoms suggestive of an underlying depressive disorder, such as feeling sad, irritable, recent onset of disobedience, deterioration of school performance, changes in sleep or appetite, and giving up previously enjoyed leisure or extracurricular activities should be looked for. Features of anxiety such as nausea, abdominal pain, or headache on school mornings and not on holidays should be inquired. Signs suggesting separation anxiety, such as difficulty from separating from parents, worries that some bad thing will happen to the parents in their absence. worried that some bad thing will happen to them in the absence of their parents, nightmares about separating from parents, and refusal to sleep without the parents should be inquired about. What the child does on days he does not go to school should be found out. For example, whether the child watches television all day, play computer games, or play when at home needs to be looked for. The steps the parents have taken so far to send the child to school should be queried. For instance, whether they force the child to go to school, punish the child physically for not going to school, have they spoken with the class teacher, etc. Parents should be advised to send the child back to school as soon as possible. Educate the parents that the longer the child stays at home, the harder it will be to send him or her back to school. Explain that when the child stays at home, he or she misses schoolwork, which will add extra stress when sending back to school. In addition, friendships may change during the time the child stays at home, making going back to school difficult. If there are any environmental stresses, educate the parents how these may lead to school refusal. If there are problems at home, you may need to counsel the parents on how to solve these problems. If there are problems at school, you should try to help to solve these issues. It may be necessary to talk to the teacher with the parents' consent to help solve these issues. Parents should not make staying at home rewarding. If the child stays at home, he or she needs to do schoolwork according to the timetables and not spend the whole day doing pleasurable activities such as watching television, playing, etc. Advise the parents not to punish the child for not going to school, as this is unlikely to help. Instead, advise the parents to reward the child on days that he or she goes to school. For younger children, star charts can be used as rewards. When using star charts, give the child a star every day he or she goes to school. Once the child gets 5 stars, give him or her a reward. The reward should be something that the child really likes. The child should be told beforehand why the star is given and what the reward is going to be. Do not advise parents to change schools unless there is a very significant reason, such as abuse occurring at school. This is because the child is unlikely to refuse going to the next school as well. The child should be referred to psychiatric services if the problem has been long lasting and the child had already missed a lot of school due to this problem. School refusal doesn't improve within a week or so despite the behavioral management. The child has symptoms of a psychiatric disorder or learning disorder. There are problems at school or home that needs to be intervened by the psychiatric team. Now we will move on to problems in elimination, which includes enuresis and encopresis. We will discuss the prevalence, causes, assessment, and management of these problems. Enuresis is the repeated voiding of urine into inappropriate places. Enuresis affects about 5 to 10% of 5-year-olds, 3 to 5% of 10-year-olds, and 1% of those 15-year-olds or older. Encopresis is the repeated passage of feces into inappropriate places. It is estimated to affect approximately 1% of 5-year-olds and is more common in males than in females. Enuresis may be nocturnal or diurnal. Enuresis may be classified as primary or secondary. The term primary enuresis is used to describe a child who has never achieved urinary continence. The term secondary enuresis is used when the enuresis occurs in a child who had previously been continent for at least 6 months. The history should aim at identifying whether enuresis is primary or secondary and whether it is nocturnal, diurnal, or both. In cases of secondary enuresis, a detailed history should be taken to identify any underlying stressors which may have triggered the enuresis. As secondary enuresis may occur as a part of underlying emotional disorders, a recent change in behavior, irritability, fearfulness, and changes in sleep or appetite should be inquired. Furthermore, a history suggestive of a urinary tract infection, diabetes mellitus, or other organic disorders should be sought, especially in secondary enuresis. Enuresis is sometimes associated with encopresis. Therefore, the presence of encopresis should also be excluded. In case of diurnal enuresis, the place where it mostly occurs should be inquired. Any reasons for avoiding the toilet during daytime, such as fear of asking permission from the teacher to use the toilet or disgust in using the school toilet, should be asked. It is also important to assess the impact of the enuresis on the child. The child may be psychologically affected due to teasing, bullying, or punishments received as a result of enuresis. Some children may refuse going to school due to bullying related to enuresis. The child's social life may be affected as he might not be able to go on trips or have sleepovers due to the enuresis. Finally, finding out how the parents have managed the enuresis so far is also important for the management. Parents may use harmful strategies to manage the enuresis, such as physical punishment or shaming the child, which may worsen rather than improve the enuresis. The main mode of treatment of enuresis is behavioral management. The parent should be educated that enuresis is a common problem and that it will spontaneously resolve with time. Parents should be told that the child has no control of his voiding and that the child is not intentionally wetting the bed. Parents should be advised that punishment will not help and is likely to worsen the problem. Children with enuresis are often subjected to teasing by their siblings. Parents should be advised that measures need to be taken to stop such teasing as it may predispose to emotional problems later on. The first step in behavioral management is making sure that the child voids regularly during the daytime. Some children have the habit of holding their urge to void till the last minute, and this may worsen bladder hyperactivity and enuresis. Therefore, the child should be encouraged to void every 2 hours or so. The child should also be encouraged to drink regularly throughout the day. Parents should be advised to maintain a star chart and reward dry nights. Parents should give a star for every night that the child is dry, and once the child has collected 5 stars, the child should be given a reward. The reward should be something that the child likes. However, black stars should not be given on the nights that the child has wet the bed. Finally, parents should be advised to engage the child in cleaning up the bed sheets or clothes, etc., as this is shown to be helpful. If the nocturnal enuresis has not improved despite behavioral management, if the child is older and if the enuresis is due to an environmental stressor, or if there is marked psychological impact due to the enuresis, the child should be referred to mental health services. 2 types of encaprices have been described. A primary type in which the individual has never established fecal continence, and a secondary type in which the disturbance develops after a period of established fecal continence. The commonest cause of encaprices is constipation and overflow. Constipation leads to impaction, retention, and subsequent overflow. In this type of encaprices, characteristically, the stools are poorly formed. Leakage can be frequent to continuous, occurring mostly during the day and rarely during sleep. Constipation may sometimes be triggered by a psychological event. Once constipation has developed, it may lead to formation of an anal fissure, painful defecation, and further fecal retention, worsening the encaprices. Encaprices may sometimes be triggered by a traumatic event such as traumatic accidents, hospitalization, or an incident of sexual abuse. Encaprices may be a result of lack of bowel control. In such cases, the child would have primary encaprices. The stools would most likely be normal, inconsistency, and the child is often not aware or unable to control the soiling. Some children may soil themselves because of their fear or anxiety about using the toilet. In some low socioeconomic households where the toilet is situated outside the house, the child may fear going outside to the toilet. Similarly, the child may be scared of the presence of bugs or the presence of imaginary creatures in the toilet. Provocative soiling occurs when the child deliberately passes feces in inappropriate places with the intention of provoking the parents. The feces would be of normal consistency and is often deposited in a prominent location. This may be associated with smearing of feces. In provocating soiling, there is usually an underlying oppositional deviant disorder, conduct disorder, or family dysfunction. The first step in assessment is determining whether the encopresis is primary or secondary. This should be followed by a detailed history of the child's bowel habits, with special attention to the presence of features of constipation. The duration of encopresis and whether it was triggered by a physical or psychological trauma should be inquired. The place where soiling takes place most frequently and the frequency of soiling should be noted. Inconsistent or harsh toilet training may sometimes lead to the development of encopresis. Therefore, a history of toilet training should be inquired. The psychological impact of the soiling on the child should be assessed. Children with encopresis often feel ashamed and prefer to avoid situations where encopresis may occur. For example, if the encopresis occurs at school, the child may refuse to go to school. These children are often teased and rejected by peers, which may lead to the development of low self-esteem or emotional disorders. Encopresis also causes significant distress to parents who may then punish and humiliate the child in order to control the problem. This may make the child fearful and he or she may try to hide the deposited feces in such cases. Therefore, it is vital to assess the impact of encopresis on the child and the family. Parents should be advised not to punish the child for soiling. The child should be rewarded for maintaining continence by using star charts. Each day that the child remains continent, he should receive a star. When the child has got 5 stars, he should be given a reward. However, the child should not be given black stars on the days the child soils themselves. If the encopresis occurs secondary to constipation, a laxative to manage the constipation is helpful. Parents should also be advised about giving a healthy diet rich in fiber and providing adequate fluids. Parents can be advised to schedule regular toilet sits about 50 minutes after meals to coincide with gastrocolic reflex. The length of toilet should be maximum of 5 to 10 minutes. Long-standing constipation, not responding to laxatives, require assessment by a pediatrician. Similarly, a child who has never achieved bowel control should be referred to a pediatrician to exclude any underlying neurological problems. If soiling has started secondary to an environmental stressor, it indicates severe psychological distress. Therefore, the child should be referred to a psychiatrist for further assessment and management. Provocative soiling indicates poor family functioning and usually needs long-term family work. Thus, in this instance, referral to a psychiatrist is warranted.